monthly. We'll add into it the amount that takes care of 50% of your office overhead. All you have to do is we'll provide you with a form, daily register form. You can put 12 names on there. We need either the name or the Social Security number of the person. And we need to have the date the service was provided, and we need to have either the diagnosis or the service that you provided. And there's room there for 12 people, 12 spaces. Your own board here in front of you to tell you when the tail light's on and when it's off or what have you. We'll pay you once a month. And the doctors said, fine, because of the fact that there was only one billing, and we made our payment in less than 20 days. Anything that went over 20 days, Miss Roach raised bloody hell about. She was absolutely insistent that that payment be made. And we were too. But we had her backing, which made it very important. Now, the significance of the retainer is very important, particularly insofar as surgery is concerned, because of the fact that rather than putting the value on the number of procedures you do, you get, as you know, the number of surgings that you do. You get paid the same amount of money regardless of when and how many surgings you do. So there is no initiative. There's no initiating force here, no economic force that says, I'll get more money if I do it this way. You're going to get paid the same amount of money. And it worked. Not only that, but it also took care of the quality of medical care. Because tied in with this, we also said, from here on out, we will not pay for surgery unless it is performed by the appropriately board-certified physician, and for a short period of time, or a member of the American College of Surgery. We had to do it that way in order to get by that particular step of that barrier. You'd be surprised what it did as far as our number of operations was concerned. Our hospital admissions dropped 60% in 90 days. And then they leveled off at about 50% of what they had been, and that's where they stayed from then on. We got frightened for fear of the fact that there might be patients that were not receiving hospitalization that should have been in the hospital. So we were constantly surveying, studying, making sure that everybody that should have gone into the hospital got there. And then that didn't, that was fine. And for instance, we found out that we had minors on whom there were 2 and 3 operations for the back cases. We looked at these records and thought, now that's a little silly. So we set up a policy that said in all back cases, there must be 5 physicians, and they must be board certified. There has to be an internist, a neurosurgeon, an orthopedic surgeon, a radiologist, and what would be the 5th one? In any event, there was a 5th specialty there. And all 5 of these physicians must agree surgery is the only way this can be treated, and that the neurosurgeon is the physician who is going to do the surgery. You'd be surprised what that did to our back surgery. We also got a drop. But you see, this is quality work then. This is quality surgery. We're not subjecting our beneficiaries to unnecessary surgery. We're saying here, sure, we're willing to do this, but we want to make awfully sure that this is what should be done. And we were even paying for a second opinion before the patient was hospitalized because of the fact that there was still evidence that the hospitalizations was running a little high. However, when you took and compared our hospitalization, rate of hospitalization, with Blue Cross, with Saskatchewan, any other standards, we were doing very well. That is, we weren't over, we were under every one of those people because they had no control with their programs.
If you were going to compare,
Pardon?
If you were going to compare the union's approach, the fund's approach, with, say, the approach of the government during the 60s,
Yes.
and that began putting on
Yeah,
the health care,
yeah.
what are the differences? Just a world of difference?
Oh, yes, there's a tremendous world of difference because of the fact that, first of all, the doctors under the 1965 Medicare program are paid on the basis of what is their usual and customary fees. We didn't have any fees. In fact, it reached the point with the fund that about 70% of the services that were provided to our beneficiaries were paid for by, or were produced. 70% of the fees, or the money paid out, went to doctors on retainers. Now, let me do it correctly. 70% of the services for which we paid was paid for by retainers. So that you can see that there was an awful lot of those doctors that said, yes, we'll go ahead and go along with the retainer. But it also meant that we had control over the quality. So what we said here is the fact that by controlling quality, you have almost an inherently cost control. When you say you're only going to pay for surgery when it's done by board-certified physician, because of the fact that we had our records as showing how much tremendous amount of gallbladder operations, of hysterectomies, of appendectomies, et cetera, et cetera. In fact, tonsillectomies was dreadful, just dreadful, far more than anybody else. We said no. This can only be done, can only be performed when a pediatrician and an ear, nose, and throat physician agree that this is necessary. And then the surgery is done by a certified ear, nose, and throat physician. For instance, when I was in Morgantown, I walked into a company doctor's establishment at a place, Shinston, West Virginia. And he had what was the company. I imagine that it probably was at one time used as a company office, administrative office of one sort or another, or it could have been a hospital. In fact, I'm not sure what it was. But he took me upstairs to show me a vast room in the middle of the building in which he had 6 well-appointed beds, and then he was going to do the tonsillectomies in a room Oh, if I didn't know about it. I said, what are these beds for? He said, well, we're going to do tonsillectomies here. I said, what? He said, yes, we're going to do the tonsillectomies here. And I said, well, you may be doing them here, but the fund isn't paying for them. He said, what do you mean? And I said, our tonsillectomies are not going to be done by you. Tonsillectomies will be done by by board-certified ear, nose, and throat physicians. And the pediatrician has to agree that this is so. And probably most of these cases will be operated in the hospital at Clarksburg. Well, that took care of that. But this is what they would have done if we hadn't have been there. The town of Shinston is about halfway between Fairmont and Clarksburg. And there isn't another doctor within several miles.
Is it all going to go back to that early stuff now?
Oh. Let's not jump the game, because there's one other thing that's necessary. That we also developed, as far as the quality of care was concerned, one other point, and that was the concept of a managing physician. We tried to have the people understand, have the minors understand, that they should be thinking in terms of going with a physician, of being under the care of a physician. And that this physician would be able to direct them to the specialists that they thought would be necessary to take care of them. And that, for instance, down in Alabama, we came up with on a study down there in which there were, I think in 1 year, as I remember the case, there was one patient that had been seen and something had been done, in some cases a little surgery, by 29 doctors. And none of the doctors were talking with each other about anything that was going on. So they did a study of patients that had been seen by something like 5 or more doctors in one period of time. And the number was unusually high. It was frightening. So what they did was to decide who was a good internist in town. They already had done this when they were going over all of this. So they put at his fingertips a nurse, whatever they needed in the way of record keeping, ready referral to any other specialty that he needed. And we told these X number of beneficiaries that in the future they were going to have to look to Dr. So-and-so for their medical care, and that they were going to have to do as he thought was necessary. And in our study, we found out that what had happened was that some of it was due to the doctors, that they hadn't differentiated. They just told them to take this or this and this, but they didn't develop any understanding with the patient, that it was the green medicine or the red medicine or what have you. They had made no effort to do any educational work with the patients at all, or to develop any lines of communication. This was really the biggest problem that there was. So he had a psychiatrist in addition to a social worker and another doctor. And at the end of the year, when we went back and took another look at this, there had been a considerable reduction in the amount of hospitalization. Now these people, some of them had been taken care of, and them that needed care were taken care of in a clinic arrangement. But this was the sort of thing that we were trying to get rid of. We didn't want that going on any longer. And this was also part of the reason that we developed built these 10 hospitals that were built down, as you know, down in southern West Virginia and eastern Kentucky, and then one over at Wise. And we had a little over 1,000 beds in those 10 hospitals. And we had what at that time was the highest ratio of personnel in the hospital to patients. We had a 2-to-1 ratio here, which at that time was high because the highest number, as I recall, the highest ratio was, I've forgotten where the hospital was located, but it was somewhere around about 1.5 or 1.6 personnel for every patient. So, and there was one of the hospitals in which we had a training for LPNs, another hospital for graduate nurses. We had residency training for doctors in Beckley. We also had residency training for surgery, as I recall, in Harlan. In Williamson, we had the only board-certified neurosurgeon for quite a few miles. So out of this arrangement, we developed a pattern of medical care that was really quite good. It was unusual. It's never been duplicated. And it had in it the forms, the policies, the procedures that it could have been put into effect on a national basis and taking care of everybody. When we needed it the most, it weren't there. You can say, well, how did it happen not to be there? Lack of understanding of what it was that the fund was doing, of all of these things. And I can remember talking to people, some of them that were involved with this, for quite some period of time, and there still wasn't any understanding of what it was that we were doing. And as a consequence, the program just was turned around and went another direction.